Okay. I will on thyroid. We have three speakers. Dr. Maji, who is a junior resident at SSM Hospital. Dr. Shayandeep, who is a junior resident at RKM Shaya. Dr. Milind Alongji, who is a junior resident at MR Bangalore Hospital. So we'll have three presentations, and after each presentation, we'll have 5 minutes for discussion. So the first presentation is by Dr. Anuradha Maji. She will speak on classification and genetics in thyroid cancer. Anuradha, can you share your screen? Good morning, and start? Sir.
Yes, sir.
Good morning.
Good morning, sir. So, shall I start?
Yes, please.
Yes, okay, sir. Okay, sir. Good morning, sir. Good morning, everyone. Today, my topic of presentation is thyroid cancer, classification and genetics. This is the table showing the classification of thyroid cancers. Thyroid cancers can be classified broadly as follicular-derived and neuroendocrine C-cell derived, which are nothing but medullary thyroid cancers, which are originating from the parafollicular C cells from the ultimobranchial body. And the follicular-derived cancers can be differentiated or anaplastic. The differentiated carcinomas can be divided into well-differentiated or poorly differentiated. In well-differentiated, we have papillary thyroid carcinoma, follicular thyroid carcinoma, and a variant of follicular thyroid carcinoma, which is known as Hurther cell thyroid carcinoma. Coming to thyroid oncogenesis. Thyroid oncogenesis is nothing but the genetic processes that lead to thyroid neoplasm. There are two important categories that has been found in general in oncogenesis, which is also applicable for thyroid oncogenesis, which is mutation of the proto-oncogenes that will result in altered protein production and accelerated growth, and loss of function in growth suppressor genes or the tumor suppressor genes, allowing unregulated cell growth. So most of these genetic abnormalities are acquired. Genetic alterations that specifically has been seen in thyroid oncogenesis are in two pathways, which are mitogen activated protein kinase pathway and phosphatidylinositol 3 kinase AKT pathway, which are causative in most common forms of thyroid cancers. Coming to MAP kinase pathway, it is activated. MAP kinase is normally activated by growth factors which are binding to the cell surface tyrosine kinase receptors, which triggered the intracellular signaling cascade that regulate the transcription of genes and for cellular growth and proliferation differentiation. Major MAP kinase pathway genes that are involved in thyroid carcinoma are RAS, RET proto-oncogene, RET PTC mutation, BRAF mutations, and NRTK, neurotrophic tropomyosin receptor kinase genes. BRAF gene is the most important stimulator of MAP kinase signaling. Mutations in RET and NRTK1 tyrosine kinases, they will result in a chimeric protein known as RET PTC and TRK respectively. RET proto-oncogene, which is basically the one of the genes in the MAP kinase that is associated with high frequency of missense mutations, especially in patients with multiple endocrine neoplasia 2A. Thyroid malignancies expressing this oncogene may have predilection for distance metastasis. RAS oncogene, which was within the pathway of MAP kinase, that encodes for signal transduction G proteins, which are one of the enzymes is guanosine triphosphatase, which cause inactivation of protein, inactivation of protein degradation. Now, mutational activation results in production of inactive form of guanosine triphosphatase, which lead to inactivation of this protein degradation. This leads to increased cellular proliferation. So 40% of thyroid carcinomas may have one of the 3 RAS gene point mutations. 3 RAS gene point mutations can be HRAS, KRAS, or NRAS. RAS mutations occur in benign or malignant thyroid neoplasms, including follicular adenoma, follicular thyroid carcinoma, follicular variant of papillary thyroid carcinoma, even in some undifferentiated thyroid carcinomas. KRAS mutations has been shown to be more frequent in radiation-induced papillary thyroid carcinomas, and it has been seen that there is slightly decreased incidence in of RAS oncogene mutation in iodine-deficient areas. Follicular thyroid carcinomas with RAS mutations are found to be more aggressive. The other pathway, which is PI3K AKT pathway, which also leads to series of phosphorylation reactions, intracellular signaling that lead to activation of AKT, which regulate cell apoptosis, cell cycle progression, energy metabolism, cell membrane integrity, and it is also particularly important in the development of follicular thyroid carcinoma. Coming to P53 tumor suppressor gene, this comes to play most importantly when there is a trend of more poorly differentiated to undifferentiated carcinomas. That's why it is a late event in thyroid carcinoma progression. Around 15% of anaplastic carcinomas usually will have a P53 tumor suppression gene mutation. It is associated with radiation exposure. It is associated with more aggressive papillary thyroid carcinoma and follicular thyroid carcinoma. And it is also associated with development of anaplastic thyroid carcinoma. This is the slide showing the genetic events which I explained previously of thyroid oncogenesis, where the two pathways act and finally they lead to poorly differentiated thyroid carcinoma and anaplastic carcinoma. Here, certain mutations like P10 mutations, then PAX8, PPAR, gamma mutations are important for a normal follicular thyroid cell to become a thyroid follicular adenoma, a benign tumor, followed by a formation of follicular thyroid carcinoma, which with P53 mutation will become a anaplastic thyroid cancer. When the normal follicular thyroid cell, they undergo RAS MYC mutations, they will directly either become Hurthle cell carcinoma, or they can originate from the follicular adenoma and lead to anaplastic thyroid carcinoma. This is the main gene. This is the slide showing the main genes involving thyroid oncogenesis. Apart from RAS BRAF mutations, we also have TSH gene, TRK gene, ERB2 gene, GSP gene, PAX8, PPAR gamma genes, which are important in thyroid oncogenesis. Coming to the individual thyroid carcinomas, papillary thyroid carcinoma, as we know, is the most common thyroid malignancy, around 85% of the cancers of thyroid gland, and it has a more female predilection. Radiation exposure is the most important etiology. Low dose therapeutic radiation of 6.5 to around 2000 centigrade to the thymus, tonsils, scalp, skin during infancy, childhood, or adolescence has been shown to be the risk factor for papillary thyroid carcinoma. Although history of first degree relatives having thyroid carcinoma is also a risk factor. 5 to 10% of papillary thyroid carcinoma are familial. They can have they can be due to Werner syndrome, Cowden syndrome, Carney complex, familial polyposis, or Gardner syndrome. Usually, it appears in early life, around 30 to 50 years of age, presents as a solitary nodule, and has an excellent prognosis and has lymphatic spread. The red proto-oncogene rearrangements occur in around 40% of the sporadic papillary thyroid carcinomas, and mutation in RET is the most common. In about 80% of the radiation-associated papillary thyroid carcinomas, RET proto-oncogene can be seen. Most common mutation in papillary thyroid carcinoma is BRAF mutation, which is seen in 40 to 50% of the papillary thyroid carcinoma. Overall, the mutation in BRAF is the most common in MAP kinase pathway. BRAF mutation occur in around 60% of the classical papillary thyroid carcinoma, around 10 to 15% of the follicular variant of papillary thyroid carcinoma, and in more than 90% of tall cell variant of papillary thyroid carcinoma. BRAF mutations are associated with lymph node metastasis and higher recurrence rate. New driver mutations which have been found are EIF1AX gene mutations in CHEK2, ATM, TERT promoter region, and microRNA alterations have also been shown to leading to papillary thyroid carcinoma, which are MIR21 and MIR146B especially. Then coming to, as we know, the papillary thyroid carcinoma has a distinct histopathological histopathology with some of the body's intranuclear inclusions, orphan annii nuclei, and coffee bean nuclei, which is the nuclear grooving, as we see. The named variants of papillary thyroid carcinoma are mixed papillary follicular variants, columnar variant, hobnel variant, tall cell variant, solid variant, and sclerosing variant. The follicular variant of papillary thyroid carcinoma, they constitute approximately 10% of papillary thyroid carcinomas, and other variants, they constitute around less than 1% of papillary thyroid carcinomas. Variant papillary thyroid carcinomas are usually more aggressive than the classical papillary thyroid carcinoma and has less favorable prognosis. This is a slide showing a papillary thyroid carcinoma and a tall cell variant with the nuclear features. Coming to follicular carcinoma, they are approximately 10% of the malignant thyroid neoplasms. They appear at around 40 to 60 years of age with a female preponderance and increased incidence in areas with iron deficiency. They are usually encapsulated tumors and follicular derived differentiated thyroid carcinomas. Occasionally, they metastasize to regional lymph nodes. They have greater tendency for hematogenous spread to lungs, bone, and rarely liver. And metastases are radioactive iodine avid. That's why skeletal mets that can appear after resection of primary tumor, they can also be picked up by radioiodine. In histopathology, we see follicular cells with capsular and vascular invasions, and the cells may not demonstrate nuclear atypia. Although marked nuclear atypia is associated with worse prognosis. That's why sometimes it becomes difficult to differentiate between a normal thyroid tissue and a follicular adenoma or carcinoma. There are two types of follicular thyroid carcinoma clinically described, which can be minimally invasive or widely invasive. The widely invasive will have more of distance spread and typically have the follicular thyroid carcinomas will have typical hematogenous spread and less favorable prognosis than PTC. This is the slide showing the specifically for follicular thyroid oncogenesis. We have RET PTC oncogene, we have the EGFR, MET, and they all and the RAS pathway, where the PI3K pathway, the BRAF gene, the MET gene, ERK gene, all these can be involved in follicular thyroid oncogenesis. And this slide also shows certain chemotherapy which can be applicable for treatment of this carcinoma. In case there is a palliative chemotherapy is being given. This is the slide showing capsular invasion in case of follicular thyroid carcinoma. Hurtle cells carcinoma is a clinical variant of follicular carcinoma. They tend to occur in older patients, usually 60 to 75 years age. Histopathology shows oxyphil cells, characteristic appearance of enlarged granular eosinophilic cytoplasm, which is characteristic of this carcinoma due to increased number of mitochondria. Hurtle cell carcinoma, they are more likely to be multifocal than follicular carcinoma, more likely to involve lymph nodes, and more likely to have local recurrence. And they are less avid to absorb radioactive iodine. There is a new entity. This is not a carcinoma, but I mentioned here since this has come in the latest suggestion. Non-invasive follicular thyroid neoplasms with papillary-like nuclear features. So they were initially thought to be follicular carcinomas, but has been seen to be quite very indolent, relatively indolent tumors, and currently not considered as malignancy. Coming to medullary thyroid carcinoma, around 4 to 7% of malignant thyroid neoplasms can be medullary thyroid carcinoma, and they lead to 15% of thyroid cancer deaths. They arise from parafollicular C cells that reside in the upper poles of the thyroid lobes, originating from neural crest cells. and they do not take up radioiodine. Serum calcitonin and serum C levels are of prognostic value. Medullary thyroid carcinoma more commonly are sporadic, around 80%, and less commonly as autosomal dominant inherited disorders. The important autosomal dominant disorders which are associated are multiple endocrine neoplasia 2A and 2B, and familial medullary thyroid carcinoma. Familial medullary thyroid carcinoma is a variant of MEN2A that include medullary thyroid carcinoma, but not the features of MEN2A, not the other features present. And FMTC occur in around 25% of the medullary thyroid carcinoma. Hirschsprung disease has been seen to be more frequently associated with familial MTC, usually due to red proto-oncogene rearrangements. And isolated familial MTC is least aggressive form. Isolated FMTC is least aggressive, most aggressive when FMTC is associated with MEN2B. This is the slide showing multiple endocrine neoplasia, where MEN2A will have major clinical components of medullary thyroid carcinoma associated with hyperparathyroidism, pheochromocytomas, lichen planus, and red proto-oncogene is important. MEN2B will have medullary thyroid carcinomas, may or may not have pheochromocytomas, neurofibromas of the lips and tongue, marfanoid habitus, and association with Hirschsprung disease. Around 1 to 7% of patients with presumed sporadic medullary thyroid carcinomas have germline RET mutations. RET testing should be performed shortly after birth in MEN2B syndrome and before 5 years of age in familial thyroid carcinoma and MEN2A syndrome. First degree relatives of patients with hereditary medullary thyroid carcinoma should receive RET mutation detected by family genetic screening. Prophylactic thyroid total thyroidectomy should be recommended for them. Coming to poorly differentiated thyroid carcinoma, this is a middle ground between the differentiated thyroid carcinomas and the anaplastic thyroid carcinomas. They are defined based on cytoarchitecture and features like mitosis and necrosis. Poorly differentiated thyroid carcinomas have around 50% mortality at 10 years age, 10 years duration. With aggressive resection, 5-year survival is just 66%. And not all poorly differentiated thyroid carcinomas absorb radioactive iodine, since they are becoming increasingly de-differentiated. Coming to anaplastic carcinoma, around 1% of all thyroid cancers are anaplastic carcinoma. They are rapidly growing and invasive, and most aggressive form of thyroid carcinoma. Mortality almost approaches 100%. They occur beyond the middle age, usually presents with a rapidly enlarging neck mass with dysphagia, cervical tenderness, and cervical lymphadenopathy and pulmonary metastasis are common. Three major types have been, histological types have been found, which are giant cell anaplastic carcinoma, small spindle cell anaplastic carcinoma, and squamous cell anaplastic carcinoma. BRAF mutations are present in around 25% of the anaplastic thyroid carcinoma. P53 mutations are found in around 15% of anaplastic thyroid carcinoma. One slide for thyroid lymphoma. This primary thyroid lymphoma is rare, account for around 1 to 2% of thyroid malignancies and less than 2% of lymphomas. Thyroid lymphoma usually occurs in pre-existing Hashimoto thyroiditis. Around 50% have a pre-existing Hashimoto thyroiditis. More of female preponderance on 4:1. And almost all are non-Hodgkin lymphomas, mostly of our B-cell origin. And most common mutation that has been seen is V600E point mutation in BRAF gene, occurring in around 40 to 50% of the cases. Thank you.
Dr. Anuradha, very nicely presented. You have covered it extensively. So I don't really think I've got much to add. I'll just ask you a few questions. So you have mentioned that the incidence of thyroid cancer is more common in females, almost 3 times as more common in females than males. So in all the genetic mutations that you suggested, say BRAF or RET proto-oncogene or PI3K pathway, Which one do you think is responsible for this higher incidence in females? Why is it higher incidence in females? Is it a genetic factor or is it an environmental factor?
Sir, genetic factors usually would not lead to higher incidence in females.
It wouldn't?
Mm,
Then how do you explain it? It is some specific environment that females are exposed to, which causes more thyroid cancer. It's a significant difference. So it's not a it's not a difference which can be attributed to chance.
I did not come across this one, sir.
So it is a genetic factor, you know. So what is subscribed, the theory subscribed is that there are estrogen receptors in the thyroid cells, which are different from the conventional estrogen receptors which are present in the uterus or in the breast. But there are receptors. The exact theoretic mechanism for that is not well elucidated. This is an area for active. Definitely, estrogen got trophic effect on thyroid cells, normal thyroid cells also. Okay, which is why the incidence is a little more common. But the exact genetic mutation is not yet well known. It has not been isolated.
Okay, sir.
Achha, another question to you is, you mentioned that the different atypical variants of papillary thyroid cancer, you mentioned tall cell variety, diffuse sclerosing, hobnailed variety, columnar. Can you tell me what is a tall cell variety and what is a columnar variety? They're both tall, isn't it? I mean, the columnar is always obviously like a column. Tall cell is also tall. So when would you call it tall cell? When would you call it columnar? Are you covering pathology or is the second person covering pathology?
Sir, I was supposed
you
to
are covering
cover
pathology.
Pathology, yes.
Pathology, sir.
So can you just tell me what is the difference between a tall cell and columnar? Okay, I'll tell you. Tall cell is more than when the height is more than twice the base. Okay, and columnar is when the height is more than three times that of base. They are both tall, but columnar is a little more tall. Okay. Another trick. These are basically, I mean, you have made a very good presentation. I don't think I have much to add, so I'm just asking you difficult questions. Have you heard of association of thyroid cancers with FAP, familiar adenomatous polyposis coli?
Yes, sir.
So which type of thyroid cancer is typically associated with FAP? Can you tell me? One histological type.
You mentioned.
Yes, sir.
No, I don't think she specifically mentioned that. There is a morular blastemic type of thyroid papillary. There's a variant of papillary CA, which is typically associated with FAP.
Okay.
Last question is, when you were mentioning the mutation, V600E you mentioned is the most common mutation, point mutation of BRAF, V600E. What does V600E exactly mean?
The locus of the mutation.
Right, so that is the 600 gene, 600 nucleotide. What is VNE?
So I'm not sure.
So V stands for valine and E stands for ethanolamic acid. So the exact amino acid which is being replaced by the other, valine being replaced by ethanolamic acid. Okay, at the point 600. So that is the meaning of these. This is language. You should understand that. Okay.
Okay, sir.
Very, very nice presentation.
Actually, Anurada, now we have the facility for getting this genetic testing in our clinical practice. So how does it alter your practice? Can you tell us?
Sir.
How? In SSK, you have the access to genetic testing. When do you consider genetic testing in clinical practice? One is identifying the high-risk patients. That is one group. Second is patient is presenting with a thyroid nodule.
Yes, sir.
And the standard practice is to do imaging and then FNA.
Yes, sir.
And in FNA, you have three groups of patient. One distinct group is benign, one is malignant, and one is indeterminate.
Yes, sir.
So how does genetic testing in this subset of patient can help you to decide about the further management?
Sir, cell-free DNA can be extracted if that comes positive, then that might be highly sensitive for carcinomas. If cell-free DNA is negative, that might not rule out thyroid carcinomas.
They have now the facility for testing for BRAF mutation,
Yes, sir.
PIC, and red proton. So these are the important mutations that can be tested now in lab, even in Calcutta. So if you have the access to the genetic testing, you can further have pointer to the diagnosis.
Yes, sir.
Okay, Saurabh, you are doing routine genetic testing for these patients?
No, sir, we don't have the facility, and sending to
SSK, they have now
Sir,
started.
if we send to
Dr.
SSK, the
Sujoy
patient
is
will
doing
not come
the-
back.
Dr.
Patient
Sujoy
will
is
not
doing
come
the
back, sir.
testing.
I know, sir. I know, but it is not yet fully conclusive. So if it's a follicular neoplasm of uncertain significance, the genetic testing definitely will be a tool in the armamentarium of the surgeon. But we just go ahead and do the operation based on frozen sand.
Okay, we pass on to the next presentation. Dr. Shayandeep, please share your screen and present the presentation and investigations for thyroid cancers. Shayandeep, unmute and start.
Yes, sir. Am I audible, sir?
Yes, you are audible.
Yes, yes.
Hi, everyone. I am Dr. Shandeep Pradhan, second year surgery junior resident. I am presenting the clinical features and investigations of different thyroid carcinoma. First is the papillary thyroid carcinoma. The most, in all of the carcinomas, the most common clinical feature is swelling in the neck. Along with that, there may be features of local invasion, which may represent as dysphagia, dyspnea, hoarseness of voice. In investigation of papillary thyroid carcinoma, there is radiological investigation. We can go for USG of thyroid region to assess the extent of enlargement of the thyroid, any invasion of the gland to adjacent structure, including extension to the internal jugular vein. In pathological investigation, we can go for FNSE. Papillary thyroid carcinoma is confirmed by FNSE. On examination, we can get samoma bodies. These are foci of dystrophic calcification, but it is not diagnostic as it can be found in other conditions like ovarian cyst, adenoma papillary, RCP, meningioma, etc. In HP, we can also find orphan eye nuclei, nuclear grooving, nuclear and cytoplasmic inclusions. We can also go for blood investigation for the thyroid profile. Thyroid antibody titer may be increased, not in all cases. Radioiodine scan can be done and whole body scan for distant grade. In case of follicular thyroid carcinoma, as I said, the neck swelling is the most common feature in all thyroid carcinoma. In case of the follicular thyroid carcinoma, one point is it is mainly found in iodine deficient areas. Then investigation, similarly, we can go for USG, but in pathological investigation, FNSE is not conclusive as it cannot differentiate between follicular adenoma and carcinoma. It may be diagnosed, follicular carcinoma may be diagnosed by demonstrating vascular and capsular invasion of the tumor in histopathological examination. Similarly, here also we can go for thyroid profile, antibody titer, and whole body scan for distant. In case of anaplastic thyroid carcinoma, these patients, this thyroid carcinoma are mainly found in elderly patients, more propensity for the female gender. In this case, there is a rapid increase in size, rapidly progressive in nature. On examination, the swelling is hard, diffuse, irregular enlargement of thyroid gland. It is immobile, fixed to the underlying structure. Carotid pulses may not be palpable, and cervical lymph node may be palpable. In case of local invasion, there will be hoarseness of voice, stridor, if there is invasion to trachea, difficulty in swallowing. Here also we can go for USG to know that to get the assessment for the extent of enlargement of the thyroid, any invasion to the adjacent structures. FNAC is done. If FNAC is inconclusive, we can go for two-cut biopsy. Medullary thyroid carcinoma, these are mainly sporadic. There can be familial cases. In case of familial cases, it is the younger age group are mainly affected. Thyroid swelling is the most common feature, along with features of local invasion. In this type of carcinoma, there will be diarrhea. There may be diarrhea due to increased serotonin, flushing due to histamine, Cushing's disease due to increased ACTH, hypertension, headache. These features can be present. In histopathology, we can get the amyloid-rich stroma.
That's all.
No, sir. In FNAC, there will be amyloid-rich stroma. When there is a medullary thyroid carcinoma, we have to also rule out the familial predisposition. For that, also we should always go for the family member screening for rate protoncogene, and for we also need to exclude pheochromocytoma. For that, we have to do 24 hours urinary catecholamine, DMA, metanephrine test. In case of thyroid lymphoma, these are mainly seen in elderly patients, 5th to 7th decade of life. Non-Hodgkin B-cell lymphoma, and the features are all thyroid swelling. In the clinical features, there may be symptoms like fever, night sweats, weight loss. FNAC is not conclusive as it cannot categorize lymphoma, so two-cut biopsy is mainly done. Thank you, sir.
Dr. Shayandeep. Hello.
Yes,
yes, you're audible.
Dr. Shayandeep, in the ultrasound evaluation of thyroid swelling, which you said is the first line for any isolated nodule in the thyroid gland, did you mention about thyroid score?
No, sir.
That is important.
You have to mention. Do you have any idea about thyroid score? Nowadays, thyroid ultrasound report should ideally be with a thyroid score, just like a breast ultrasound or a mammogram should end with a BI-RAD score. So can you elucidate, or shall I say? Will you say or will I say? Do you have any idea about thyroid score?
Thyroid is thyroid. One is the normal thyroid ultrasound. In case of thyroid 2, mainly the cyst, thyroid cyst.
Yes, that is okay. That is okay. But what is the basis? What is the basis? How do they come to decide that this is thyroid 1, this is thyroid 2, this is thyroid 5? The 1, 2, 3, 5 is almost corresponding to that of breast. So that is that is easy. How do they decide? There are five features which they look at. First is composition, whether it is purely cystic, or whether it is spongiform in appearance, or whether it is totally solid, or it is solid with cystic area, and each has got a score from 0. Like pure cystic, they give a score of 0. Okay. Then the next point is ecogenicity. If it is totally anechoic, again, that gives a point of 0. Heterogeneously hypoechoic will get a point of 3. And hyperechoic will get a point of 1, and things like that. Then there is shape. If the nodule is tall more than wide, that gives a higher score. Whereas if it is more wide, it is following the contour of the thyroid lobe, then it is more likely to be benign and gets a lower score. The next point they see is margin of the nodule. Okay. If the margin is smooth, then that gets a low score. If it is a crenated margin, then that gets a higher score. If it is an infiltrative, diffusely infiltrative margin, that gets a higher score. And the fifth point is area of ecogenic foci, that is calcification, specks of calcification. So composition, ecogenicity, shape, margin, and presence of calcification. These are the things they assess to assign a score. Malignant nodules are more likely to be hypoechoic or heterogeneously hypoechoic, more likely to have calcifications, more likely other than irregular margin.
Okay, sir.
When would you consider doing a PET CT scan, Dr. Shanti, in a thyroid tumor? Any role of PET CT scan?
So when we think that there may be there can be metastatized to the features of mets, to distant mets.
How will you get a distant met? How do you know there is a feature of a distant met?
Sir, features of distant mets, like the most common distant mets that mainly occur is to the lungs. So in case of
Okay.
any, so in case of patients
So
having,
you have got units.
yes, sir.
Yes, go on. In case of patients having
Any respiratory distress or any patients with
so you will not do a chest. The patient is coming with respiratory distress. You will not do a chest X-ray. You will do a PET CT scan.
no, sir. First, I'll go for chest X-ray only.
So if the chest X-ray is showing multiple nodules,
Yes, sir.
that is not enough. In a known patient of papillary, you have to go for a PET CT scan to prove it.
No, sir.
Then why would you do a PET CT scan? I would say that the patient is a known patient of, say, anaplastic cancer. She has got a large thyroid swelling. FNAC is saying anaplastic cancer, and she's got respiratory distress, and you get a chest X-ray done, and you see multiple cannonballs, large sized in both lungs. Typical. Why do you need a PET CT scan? She's going to die anyway. Why do you want to spend 25,000 rupees of her money getting a PET CT scan done for that? So when will you ask for a PET CT scan? In a differentiated thyroid, say in the management of a differentiated thyroid cancer, normally after the operation, we go for a radioiodine scan. When would you consider a PET CT scan?
Does all different thyroid cancer takes radioiodine?
So sir is giving you a clue.
No, sir.
So how do you detect
So
that?
what is that? So I give you a scenario. I have done a total thyroidectomy for a papillary thyroid cancer, say 4 years ago or 3 years ago. And now I find that the serum thyroglobulin on follow-up is rising. After a total thyroidectomy, the serum thyroglobulin should be almost undetectable, very low values. But I find that it is very much detectable and it is rising. In fact, 3 months ago, it was say 4 nanogram. Now it has gone up to be 11 nanogram. I call her after 3 months and now I find it is 30 nanogram. So there is something wrong. And I asked for a radioiodine scan, but the radioiodine scan does not show any uptake anywhere. So do you know what this condition is called? This is known as Kinase syndrome. Thyroglobulin elevated negative iodine scan, TENIS, Kinase syndrome. So in these cases, because iodine uptake depends on the differentiation, and if you remember the first presentation, Dr. Anuradha said that they gradually tend to become undifferentiated, the poorly differentiated. And so they lose this sodium iodide symporter that takes up iodine. But they still are metabolically active because these are more aggressive tumors. So they will still take up glucose. So in these cases where the thyroglobulin is rising, but the iodine scan is not showing any metastasis elsewhere, clinically also you're not getting anything in the neck. Maybe there is something in the mediastinum, maybe there is a small focus in the lung, maybe there is a focus elsewhere in the bone, in the brain. In that case, you can do a PET CT scan and it will often show you a metastatic focus. Okay.
Okay, sir.
And Shayan, the way you mentioned the investigation, I did not like the approach. Because if you go the pre-op evaluation of patient thyroid cancer, a whole body scan is not part of pre-op investigation.
Yes, sir.
Before you do thyroidectomy, there is no role for doing whole body scanning. Why?
Yes, sir.
Why don't you ask for whole body scanning in the pre-op phase of thyroid cancers? Got my point?
Yes, sir.
You do a whole body scanning at pre-op evaluation.
It will be no use. Why?
It is no use. Because if you give the patient radioiodine, this activity will be taken up by the normal thyroid gland, which is functioning. And you cannot detect a distant metastasis. So, yes, Dr. Ghosh.
So, metastatic or a neoplastic thyroid can never compete with normal thyroid for iodine. Normal thyroid will take up every bit of iodine that you give, and the metastasis will not get a chance to take it. So, if you want to display metastatic spread of differentiated cancer, you first have to ablate the normal thyroid. So that is why pre-op there is no role of doing a radioiodine scan. Except in a very specific indication, that is a solitary nodule with features of thyrotoxicosis.
Yeah. So you think of the approach. The point was approach to a patient for thyroid cancers. You need not go to each of these papillary, follicular, because investigations are overlapping. It's not that for papillary do one-set investigation, for follicular different set investigations. So the idea was to give a presentation of how these thyroid cancer presents. Differential thyroid cancer presents in one way. It is very difficult to diagnose medullary thyroid cancer on clinical grounds unless you have some other features of MEN. Because you cannot give a diagnosis of medullary thyroid cancer based on his presentation of swelling, some local invasion, hoarseness. They're all overlapping features.
Yes.
Okay. The next was the investigations. So investigation will be again a quadruple assessment. Your thyroid profile study, imaging, and the pathology. I mean the FNA and selected cases to cut. And then you have not mentioned about the genetic studies. In borderline or intermediate cases, there is now a role for doing genetic studies which can point you to a diagnosis of likely. It's not 100%. Sometimes the genetic studies cannot give you a pinpoint diagnosis of malignancy, but in an indeterminate situation, you may have a lead that that this mutation has occurred. There is likely that this patient may have a malignant thyroid. Okay, so the approach should be different. Okay, it presented well, but what I'm saying is you think of the pre-op evaluation, pre-op investigations, and then post-op. When do you do whole body scanning in thyroid cancers? When? In the post-op period? You have done a total thyroidectomy.
Every patient of differentiated thyroid cancer, after total thyroidectomy, do you need to do a whole body iodine scan, radioiodine scan? Or there are certain high risk features?
Sir, after surgery, after total thyroidectomy, we should monitor the TSH level.
TSH level? TSH level, that means, obviously it will go up. It will go up if you don't suppress. What are you looking for? TSH level.
What is the idea? What is the idea of doing a whole body scanning?
When will you do it?
One answer can the exam can be, sir, I'll do a baseline whole body scanning. The baseline whole body scanning can be done in all patients where you detect any residual tissue in the neck. You have done a total thyroidectomy, but you may have residual tissue in the neck. And second is you may have some distant metastases which are not revealed. Okay, and what Dr. Ghosh is saying is there are some high risk features which may suggest metastasis, and you need to document that patient has got distant metastasis which needs to be treated with a mega dose of radioiodine. Okay, that is the idea of doing whole body scanning. What should be the TSH level before you embark on doing a whole body scan with radioiodine?
100.
More than 30. It has to be more than 30.
More than 30.
Earlier,
for a satisfactory uptake.
Okay. One more question. While doing this radioiodine scanning, you need the patient to be off from thyroxine subsequently for about a month. But these are the patients who develop features of hypothyroidism. How else you can do this thyroid scan early before you embark the patient to a phase of hypothyroidism?
Correct. Suppose they are thyrocardiac, they have got severe cardiac disease, they will not tolerate hypothyroidism. Or they have some other problem, connective tissue disorders, they have got spasm, they've got Raynaud's, and they cannot tolerate the cold.
Yeah. What are the alternatives? Instead of stopping, because you are doing in follow-up, you are doing thyroid scan and you need to stop L-thyroxine. What are the other alternatives where patient can be taken for this study early?
Sir, before instead of L-thyroxine, we can give triiodothyronine.
Good.
switch.
That is not available always, but yes, that is an option. You can stop for 7 days and go for it. What else?
So
Your drug, which you can give injection for 3 days and you can do the.
he doesn't know, sir. There is a recombinant TSH,
Yeah.
So there you don't need to put the patient off at all. You immediately give recombinant TSH and the TSH value rises. So you can do the radioiodine scan in a very short while.
Yeah.
You don't have to wait for the body's TSH to go up. You give recombinant TSH, but it is expensive. So normally it is not.
Okay, we pass to the last presentation. Yeah.
So can we use technetium 99M instead of iodine for the radio? For the
Shayandeep, there is a question. Is a 99 name technetium scan is equivalent to radioiodine scan?
Yes, sir. Technetium. What?
Is a 99 name technetium is as good as a radioiodine scan? A metastatic thyroid will also uptake 99 technetium scan.
It mainly technetium that scan mainly helps in the diagnosis of Hutchinson tumor.
Takes up by Hurdle cell.
Huttle. Yes, sir.
No, even different thyroid cancer, other varieties also takes up 99 technetium.
It can tell the uptake by the gland, but cannot tell.
Yes. Yes. Any vascular tissue will take the 99 technetium.
For thyrotoxicosis, they're using it nowadays. They're using technetium.
Yeah. So we pass on the last presentation, management of thyroid cancer and follow-up. Dr. Milind, second year PGT at MR Bangalore will present.
Good morning, sir. Are my slides visible?
Yes, visible. Please carry on.
Good morning. I'm Dr. Milind Alokji, and I'll be presenting my presentation on management and follow-up of carcinoma thyroid. Now, before starting with the management part, we just briefly go over the AGCC8 staging of thyroid carcinoma. Now, AGCC covers this under two main headings. One is thyroid for differentiated and anaplastic carcinoma, and the other is thyroid for medullary carcinoma. Now, under the heading of differentiated and anaplastic, they cover papillary, follicular, Hurtley cell, poorly differentiated, and anaplastic or undifferentiated carcinomas. The regional lymph node is defined as the central lymph nodes are defined as level 6 and 7, and lateral as 1, 2, 3, 4, and 5. And the first level of nodal metastasis most common in case of thyroid are the parapharyngeal, paratracheal, and the pre-laryngeal or the Delphian nodes. Metastatic site, the distant metastasis in case of differentiated thyroid carcinoma is at diagnosis is seen in 2 to 5% patients, and the most common site is the lung parenchyma followed by bone and the brain. In case of medullary thyroid carcinoma, the distant metastasis at diagnosis is seen in 1 to 5% patients, and the common locations are liver, lung, and the mediastinum. Now we come to the AGCC8 staging. First of all, the T staging. Now in this case, Tx is primary, cannot be assessed. T0 is no evidence. T1 is size less than 2 centimeter, limited to the thyroid. Now in this, now they've subdivided into T1A and B, size less than 1, and more than 1 but less than 2, less than equal to 2. T2 is size more than 2 but less than equal to 4, limited to the thyroid. T3, in case of T3, the tumor can either be of size more than 4 but limited to the thyroid, or there is a gross extrathyroidal extension invading only the strap muscles from a tumor of any size. And finally, T4 is tumor of any size with a gross extrathyroidal extension, T4A and B. Now, I would like to explain this better with a pictorial representation. Now, here as we can see, T1 is when the size is less than equal to 2 centimeters and limited to the thyroid, whereas T2 is when it is more than 2, less than equal to 4, and limited to the thyroid. T3A is when the size is more than 4 centimeters but it is limited to the thyroid, and T3B is when there is a gross extrathyroidal extension but it invades only the strap muscles. Now T4A is tumor with a gross extrathyroidal extension of any size. A being extending to the subcutaneous soft tissue, larynx, trachea, esophagus, or recurrent laryngeal nerve. Now here, as you can see, subcutaneous tissue in the trachea and in the esophagus. And T4B is when it invades the prevertebral fascia in cases of the carotid artery or the mediastinal vessels. Now the difference, next we come to the nodal staging, where we see that N0 is where no regional lymph node metastasis is there. But now in the 8th edition, N0A and B, where A is one or more cytological, histologically confirmed benign lymph node, and B is no radiological or clinical evidence of local regional lymph node metastasis. N1 is regional lymph node metastasis present. N1A is to the level 6 and 7, and B is to the lateral, unilateral, bilateral, or contralateral lateral lymph nodes or retropharyngeal nodes. For the M staging, M0 is no distant met, and M1 is distant metastasis present. Now, prognosis staging. Now, this is the staging that the AJCC gives. This is for differentiated carcinoma. The one difference that there is that earlier they used to use the cutoff age of 45 years and now 55 years. For anaplastic, anaplastic, the important feature here is that whatever the T or the N or the M might be, it is always a stage 4 disease. And for medullary, this is the AJCC prognostic staging. But more importantly, the prognostic staging that are used are the Aegis, the Ames, and the Masses system. Now, these are the Aegis system. Basically, it is the full form is the features that it covers is age, tumor grade, tumor extent, and tumor size, and it gives the 20-year survival. The Ames system covers age, metastatic disease, extrathyroidal extension, and size, and it gives a low risk and these are the 4 systems. The Masses system gives metastasis, patient age, completeness of resection, local invasion, and tumor size. But another very important prognostic system that is used is the one given by the American Thyroid Association. Now they give the risk stratification as low risk, intermediate, and high risk. Now in this case, the high risk is one where it is a follicular thyroid cancer with extensive vascular invasion, pathological N1 with any metastatic lymph node more than 3 centimeters, gross extrathyroidal extension, or incomplete tumor resection. And low is when it is an interthyroid encapsulated follicular variant of PTC, well differentiated, or the other PTC with no local and distant metastasis. And then there is an intermediate stage where there is an aggressive histology or PTC with vascular invasive, microscopic extrathyroidal invasion, clinical N1 or more than 5 pathological N1 or RIA, radioiodine uptake, avid metastatic foci in the neck, and multifocal papillary microcarcinoma with ET or BRAF V600E mutation. Now we start with the treatment of the differentiated thyroid approach, surgical approach. If it is a 1 to 4 centimeter PTC without based on clinical scenario, then we can go for a lobectomy or a hemithyroidectomy. But if it more than 4 centimeters, we go for total or near total thyroidectomy. PTC with neck node metastasis, a therapeutic central neck dissection is performed with the initial thyroidectomy, but prophylactic lateral neck dissection is not recommended. And prophylactic central neck dissection is the role is controversial. Now, in case of adjuvant therapy, the acceptable TSH levels, if the acceptable TSH levels are 0.5 to 2, then then it indicates a low risk of recurrence. 0.1 to 0.5, intermediate risk, and less than 0.1, then it's a high risk of recurrence. Now, indications for radioiodine remnant ablation is high risk of recurrence. That is, can be given by masses more than 6 or by the ATA classification. Diagnosis of follicular or an HCC, or intermediate risk in some cases. Now, what is this post-operative radio-remnant ablation? It is performed approximately 6 weeks after near total or total thyroidectomy. Now, before RRA, a pre-therapy scan using low dose of iodine 131 or iodine 123 can be done. Patient has to be made hypothyroid, and the goal is to increase the serum TSH to more than 30 international units per liter. And this ensures that there's an optimal uptake of radioiodine both by the normal residual thyroid and the thyroid cancer. Serum thyroglobulin level should be obtained during this period of hypothyroid state, and patients should be on a low iodine diet for 1 to 2 weeks before the scanning. Now, in some cases, we can use a recombinant human TSH, and this is preferred when it is difficult to render the patient frankly hypothyroid, such as in the case with the metastatic PTC in the central nervous system. After the RRA, a whole body iodine scanning 1 week can be done 1 week after iodine 131 treatment, and this is to identify the metastasis. The most common side effect of RRA is silentinitis, nausea, and temporary bone marrow suppression. And there is a weak but a dose-dependent relationship with iodine 131 and secondary malignancy. Women should be told to avoid pregnancy during 6 to 12 months after treatment due to risk of miscarriage and fetal malformation. Now, there is an entity called as papillary thyroid microcarcinoma. Now, these are defined as PTCs with a maximum diameter of less than equal to 10 mm, and they are found incidentally. The prognosis is excellent. The cervical recurrence is not associated with increased mortality, and the and as long as complete resection is possible, more extensive surgery and RRA do not seem to influence the recurrence of mortality. The most common site of recurrence is the cervical lymph node, and therefore the central compartment exploration can be performed at the time of the initial surgery to remove the involved nodes. Now, long-term surveillance in case of PTC, the goal is to identify the recurrence in patients thought to be free of disease, and thyroglobulin is an important surveillance marker. After successful thyroidectomy and ablation of residual tissue, the thyroglobulin should be in athyrotic range, and if it is a greater level, that means that there is a persistent functioning thyroid tissue or carcinoma. Now, the follow-up in case of PTC is controversial. Method that can be done is that TSH along with thyroglobulin, anti-thyroglobulin yearly for at least 5 years, because this is the period during which the most of the recurrence occurs, and after this it depends on the risk of the recurrence. The ATA says that in case of low risk thyroid cancer, an yearly neck examination for 5 years from thyroidectomy with ultrasound and thyroglobulin only done when the clinical concern for recurrence is there. But otherwise, neck ultrasound should be done at 6 months and 12 months after surgery, and then annually for 3 to 5 years, depending on the patient's risk for recurrence. Now, management of local recurrences. If significant nodal loco-regional recurrence in the neck is there, then we go for an MRND or a central compartment level 6 neck 7 neck dissection. If there is invasion in the aerodigestive tract, then we must go for a more radical surgery. For smaller regional lymph node metastasis or patients who are not amenable to surgical therapy, we can go for a loco-regional disease control, which can also be done by USD-guided percutaneous ethanol ablation. In case of metastatic disease, which is detected by a whole body scan, it can be treated with high-dose iodine 131, which is performed every 6 to 12 months as long as the disease continues to respond. But the limiting side effect of this is pulmonary fibrosis. Now, patients with incurable pulmonary disease, palliative treatment using laser ablation or EBRT may be considered. For symptomatic bone lesions, we have a combination of treatments, including surgery and iodine 131 treatment. And for CNS metastasis, complete resection is the most efficacious treatment. But if that is not possible, then EBRT and gamma knife. Now, the ATA guideline says that for that empirical radio ablation RA therapy it should be done. It can be done in patients with significantly elevated serum thyroglobulin, or in case of rapidly rising serum thyroglobulin or rising anti-thyroglobulin antibody levels, in whom imaging has failed to reveal a tumor source, that is in whom imaging has failed to reveal a tumor source that is amenable to directed therapy. Now, there are some systemic agents that may also be used in this case. For example, doxorubicin, palliative EBRT, especially in the case of unresectable residual cervical disease, painful bone metastasis. Targeted molecular therapies such as tyrosine kinase inhibitors such as sorafenib and vandetanib, and enrollment in certain clinical trials such as MEK1 and 2 inhibitors, selective BRAF inhibitors, and mTOR inhibitors. Now, next we come to management. In case of follicular thyroid carcinoma, at any stage we go for a radical total thyroidectomy if it is resectable. For Hertley cell, at any stage we go for a radical total thyroidectomy and a modified bilateral neck dissection. Then we come to anaplastic thyroid carcinoma. Now, all ATCs are classified as stage 4, and they require a multidisciplinary team approach. As resectability is assessed, and local regional, if there is local regional disease plus grossly negative margin is achievable, then we go for surgical resection. And if it is unresectable or high risk, then we go for neoadjuvant radiation or chemotherapy. Adjuvant therapy with radiation, with or without chemotherapy, should be considered for all patients, both in the resectable and the unresectable category. But if only palliation is can be done, then we must go for hysterectomy and novel palliative chemotherapy agents such as doxorubicin-based therapy and doxorubicin and other drugs. Finally, we come to medullary thyroid carcinoma. Now, in this case, we go for a total thyroidectomy with the central compartment node dissection. For familial MTC, a total extracapsular thyroidectomy should be done. If there is no evidence of neck node metastasis and no evidence of distant metastasis, in that case, lateral neck dissection can be done if serum calcitonin level is more than 200. But if there is a evidence of lateral compartment disease with or without distant metastasis, then we must go for an ipsilateral lateral neck dissection, a central compartment dissection. This has to be done. Along with this, if calcitonin level is more than 200 in this case, then we go for a contralateral lateral neck dissection. Now, post-operative replacement levothyroxine therapy should be done with the aim to make the patient euthyroid. Post-operative RIA is not indicated in this case. Serum calcitonin and CEA should be measured at 3 to 6 months after surgery. And in case of an evidence of a biochemical cure, imaging is repeated at 6 to 12 months after surgery to establish a baseline. Now, if calcitonin is detected but less than 150 post-operatively, then imaging of the neck has to be done in an evaluation for persistent disease. Now, if disease is evident on imaging, then we repeat neck dissection. But if the imaging of the neck is negative, then patient should be followed up with physical examination, measurement of calcitonin, CA, and ultrasound every 6 months. And if the calcitonin or CA begin to rise, then again imaging to look for metastatic disease. If the calcitonin is more than 150, then evaluation for distant metastasis has to be done, particularly if it is more than 300, and this includes imaging in the form of CT neck, chest, abdomen, bone MRI, dotatate PET CT, or an FDG PET CT. Now, tumor progression can be evaluated by using the RECIST criteria or tumor marker surrogates such as calcitonin, CA, doubling time. And if the disease is evident on imaging, the goal is to prevent complication of progressive local or metastatic disease. This can be done either by neck dissection to obtain a surgical cure or palliative debulk. For medullary thyroid carcinoma, the role of systemic agents is limited, but agents such as vandetanib and sorafenib and sunitinib are there. Chemotherapeutic agents include doxorubicin, dacarbazine, cyclophosphamide, and others. Now, just a word on primary thyroid lymphoma management. The CHOP regimen is used of 4 to 6 cycles, and they are given in 20 doses divided over 4 weeks. Briefly about thyroidectomy, indications of thyroidectomy include malignancy, goiters causing pressure effect, cosmetic issues and toxicosis, nodules causing pressure effects, cosmetic and toxicosis, and persistent painful lesions. Contraindications are Graves' disease, amenable to pharmacological control, stage 4 malignancies and lymphomas, and carotid encasement. Now, the different type of thyroidectomies. Total thyroidectomy is when we both the total lobectomies along with hysterectomy. Subtotal is both the subtotal lobectomy on both the sides plus hysterectomy. Near total is total lobectomy plus hysterectomy plus subtotal on one side, and lobectomy is total lobectomy plus.
Sir, I'm sorry to interrupt. I have to leave now. I have a operation. So
Okay.
sorry.
Yeah, please.
Thank you.
Pre-op workup, hematology, basic biochemical investigations, and indirect laryngoscopy. And complications of thyroidectomy include hemorrhage, respiratory obstruction, recurrent laryngeal nerve palsy, thyroid insufficiency, thyrotoxicosis crisis, wound infection, hypertrophic crisis, chest cancer.
Okay. So if you talk of this type of thyroid surgery, subtotal thyroidectomy is not a surgery for thyroid cancer. Okay, for any thyroid cancer, we can either consider lobectomy for microcarcinomas or personal less than 1 centimeter low risk patient.
Yes.
But you've got the idea, the spectrum of surgery, any types. Okay. So in follow up, we already discussed that we do a whole body scanning. But in medullary thyroid carcinoma, what do you do?
Sir, we follow up using CEA, serum CEA, and serum calcium.
Yes, there is no role for doing a radioactive iodine scanning in medullary thyroid cancer. And another important thing is medullary thyroid carcinoma. You should screen this patient for other malignancies. Okay, so it's 9-5. Okay. Any question from any of the candidates? Anything in the chat box? No. Any question? Okay. Otherwise, just bye.
Sir, may I ask a question?
Yes, Amitendu.
Sir, I want to ask a question regarding the technetium scan. Sir, in case of parathyroid or thyroid, sir, we can use both. Or in case of technetium scan, sir, both gland will be uptake, sir.
Yes, yes. Techniques are taken by both parathyroid and thyroid. It will be overlapping. You cannot differentiate the parathyroid separately unless you do a system scan.
Okay, sir. Okay, sir.
Okay. Thank you. Thank you.